Okay.
So, yeah, good afternoon.
Good afternoon. Go ahead.
Can you hear me well?
Yes.
Okay. So yeah, sorry, but yeah, I'm also a bit on a hurry because I'm speaking again at 12:50 in another conference. So yeah, well, just first to say, I would have loved to be there today with you, but yeah, well, I have some other stuff running in here that did not allow me. But well, I hope that you're having a great conference in there. So I'm going to speak about the digital health strategy for Catalonia. And which is, I would say, our thinking process behind this, and which is the conclusions that that we reached and how we are going to move forward. So the first thing is, I mean, I would like to talk about data in healthcare. And I think that this will be a story that, well, that most of you will be able to relate, and it will sound familiar for sure. So just to start with some very few highlights about Catalonia. This is a region in the northeast of Spain, 7.7 million population. We have a pure beverage model financed by taxes. And I would say that one of the main characteristics of our healthcare ecosystem is the strong fragmentation at the service provision side. And this is due to the historical evolution of our healthcare system. This was a very wealthy region. And well, you know that with wealth, healthcare developed early. And therefore we have many healthcare organizations with a very long tradition. We are talking in here about healthcare organizations that have maybe 300 years of history. Thus, they have their own personality. And this has been the same, or this also applies to the information system selection, where they have always had the ability to decide on their information systems. This region has been also, I would say, one of the front runners in Europe in digital health adoption, and we have been able to establish what we call the Catalan digital health platform, which is a series of, I would say, longitudinal technologies that are lying in the middle of our healthcare system, and that they are somehow helping us to put some glue within this fragmentation. This is an uglier visualization, but I think it's easier to understand of the last picture. So this is years here in the left. We are talking about the 80s and 90s. It's when we did the digitalization of the healthcare sector. This is the generation 1 EMRs that Alastair was talking about, emerging from Rachel's slide. So here it's the vertical systems helping us to deliver or to facilitate or to support healthcare delivery in primary care, in specialized care, intermediate care, or in community mental health. And this is generation 1, 80s and the 90s. Then, well, moving throughout the years, we started to work on this generation 2 EHRs, which is, well, let's start joining these different EMRs, these different verticals. We built the shared electronic health record of Catalonia in year 2007. This is a big repository, HL7 CDA. We also have in here all the ambulatory prescriptions, and we have here a unique therapeutic plan, ambulatory therapeutic plan. And we also have here inside of this infrastructure, what we call the Syndecat, which is a unique PACS infrastructure for all the Catalonian healthcare ecosystem. that works as the center of a federation of PACS systems. And this allows us to take advantage of economies of scale and reduce the amount of data that each of the service providers are storing at their facilities. In 2009, emerging from a subset of this information from the shared electronic health record of Catalonia, we were able to put in place the personal health folder, which is called My Health. Then in 2014, trying to foster and moving towards this, trying to achieve this continuity of care in between the different healthcare levels and service provider organizations, we built a care process management tool, which is called IS3, which is basically dealing with referrals, and it also includes some forms to facilitate this interaction in between the healthcare levels. And then I would say that as everywhere else, we've been trying to move the boundaries of our healthcare facilities towards the patient's home. And then in 2017, we deployed 2 big projects. One is the remote consultations, either the synchronous and the asynchronous model, and also a framework, I would say, and some open APIs to integrate mobile health apps and telemonitoring solutions with our digital health platform, and also, with the personal health folder and the shared electronic health record of Catalonia. So this line is separating what is happening inside of the healthcare system and what is happening, so to say, outside of the healthcare system at the patient's home. And I must acknowledge that we are quite happy with the situation. I mean, we've been able to advance a lot. When we try to understand in terms of the data that we are collecting, we acknowledge still, even though we have a very strong primary care here in Catalonia, the truth is that we must acknowledge that the biggest source of information remains being the hospital information systems and all the subsystems around the hospital setting. So acute care is still the first producer of health-related information. In our case, we wanted to survey which is the amount of information, or at least to try to understand which is the types of information that these hospitals are holding. In Catalonia, we have 71 hospitals, 13 of them big tertiary hospitals, high technology. They are using 29 different vendor products as EMR systems. And emerging from this survey, we identified around 800 silos of information in each tertiary hospital. The same survey, when we conducted it in secondary or smaller hospitals, we identified around 400 silos of information. All in all, and this is a prospection, so this is a calculation, we could not survey all hospitals. Our calculations is that we currently have here in Catalonia around 16,000 silos of information, in which the information of our citizens is split. And the EMRs in hospitals remain being the biggest source. But this is growing fast due to this idea of moving the boundaries of the hospital setting into the patient's home. And well, when we look into the data models, it's a strong heterogeneity of proprietary data models. Here you have some numbers. This is basically the same. So this is numbers and the historical evolution of our digital health platform. As you can see, the shared electronic health record of Catalonia has more than 1,000 million documents. I would say 70% of the information is structured. The care process management tool has been able to manage more than 20 million referrals, more than 25 million remote consultations, or 6 million citizens out of the 7.7, 6.1 million citizens that are actively using the personal health folder. So this is for you to have some numbers. So And that's the current situation. And now that was the current situation. And now I would like to talk to you or with you about the future and how we see the future. And first, in order to do such, is to acknowledge all the limitations of our current healthcare delivery model, and also the limitations of our information systems model, because one may think that we should be happy with what we have, but we were not happy. So this is the reflection. First reflection. Obviously, I don't want you to understand this. This is the infrastructure that is behind the shared electronic health record of Catalonia. So my message in this is that we have a very complex ecosystem of systems, and that the integrations, well, I'm surprised that with all this big mess that we have underneath in here, we are managing for this to work. And it's not only us. I mean, this is a tweet for a very well-known, from a very well-known CIO in the US, who says that, well, the hospital board says, just uninstall the old EMR and put in a new one. And the CIOs think that, well, this is the drama that we have underneath. And that's, I would say, true for every hospital or for every healthcare system. The second thing that we question ourselves is whether our current model of information systems, which is all these EMRs or different systems that talk in between them through interoperability, and we even put in place some care process management tool to facilitate this interoperability among these different systems. And with this big repository of information, which is the shared electronic health record of Catalonia, whether does this support the so-called patient-centric care, which is what our business leaders are all the time talking about. And well, we should not lose from sight that this is where most regions and countries in Europe are moving nowadays. So when we talk about the integrated care systems in the UK, the image that I have of the integrated care systems in the UK is something similar to this. Well, this is a road that we have already gone through, and we have reached to an end of this road. And my conclusion with this is that we are not doing so. With this, we are not supporting patient-centric care. And what we are truly doing, it's what I call legacy-centric care. And legacy-centric care has some characteristics, according to my understanding. The first one is that it focuses on the applications and not in the care process. So as legacy systems are so embedded in our healthcare systems and they are so difficult to replace, we decide to not change them and, well, try to tweak them in a way that they can foster some sort of, in a way, the continuity of care. The second characteristic is that we keep on talking about referrals. We keep on talking about shifting the responsibility from one healthcare level, from one service provider organization, from one provider or professional to the other. And within these referrals, transitions emerge. And within these transitions, it's where we lose patients and where there's risk for safety and security, risk in medication reconciliation, blah, blah, blah. Following the model of the legacy-centric care, we have limited data exchange, and this is obviously limited continuity of care. In this scenario, when we are exchanging in between two systems, maybe 2%, 5% of information, just sending the patient identifier, then maybe some motivation for the referral, and then we just wait until we get some result back. I mean, this is not fostering truly a continuity of care, or at least the continuity of care that you will be able to achieve with this will be limited. The next thing is that, well, this is perpetuating the fragmentation, and obviously this is not patient-centric. So I tell my business leaders, you should not limit yourselves about the current model of information systems that you have, You need to think without thinking in the systems, because if not, you are limiting yourselves and you are truly not doing patient-centric care. So our model is a model that has many limitations. Other than that, we have a lot of applications, as I mentioned before, with the business logic and the data models buried in there. These applications, due to an early digitalization, are getting old-fashioned, and every single euro that we are investing in them goes to technical debt. The interfacing in between these applications through static and limited interoperability and ad hoc interfacing, it's the never-ending story. We know everything about interoperability, and this is the never-ending story. We can be plugging in things until the end of times. This is costing us a lot to maintain. It's difficulting us to scale up innovations, and this is also a model which is very rigid and doesn't foster adaptation to change. Our answer to this was in year 2017. We wrote the digital health strategy for Catalonia. You have it somewhere accessible in English. We can share it. It's linked to the business strategy, so the health plan in Catalonia, and there's a full alignment in between the two. The main characteristics of this strategic plan or this digital health strategy is to be able to consolidate what we call a person-centered model of information systems, because, as I mentioned before, we acknowledge that the current model will never be person-centered, that the limitation will be the limited capabilities of our information system model in order to be able to deliver patient-centric care. We wanted to establish a stronger governance in between our service provider organizations that, as I said, they have the ability to decide on their information systems. Obviously, as with every other strategic plan, we wanted to establish a financing framework, a roadmap for implementation. And then with this, well, we think that we would be able to overcome all the limitations that we have currently, and also to foster innovation. The strategic plan comes with 15 different strategic lines, but our main focus is the first two vectors. We have grouped them in 5 vectors. The most important ones for us is these 2 vectors, and concretely building the foundations of this new electronic health record of Catalonia. We understand this longitudinal electronic health record of Catalonia as this repository of information that will contain all the contacts of a specific individual with the healthcare system since before they are born until they die and afterwards. And this will be a technical and functional repository, also including all these longitudinal care pathways. So in a way, advancing in the same way that the healthcare model is advancing towards more coordinated care models, where professionals from different healthcare levels and different service provider organizations work together towards solving the health challenges of individuals. In order to do this, we made some decisions. The first one was to decide where to start this. And for us, where to start this, our decision has been, let's start this in ambulatory care, in primary care, basically because for us, primary care is the backbone of our healthcare delivery model. It's the place where citizens always land. So you always have, your GP will always have, or your primary care team will always have the visibility of you in a longitudinal way. And then with this, we will just connect with all the episodic contacts that you will have with acute care or intermediate care. In order to build these foundations of this new EHR, we have selected openEHR as the standard because of all these motivations that you have in here. I mean, we have strong governance of clinical data models. There's a lively international community behind. it's thought for the persistence of the data, as Alistair was saying before. It's maximum granularity, and you don't have the extension as in the resources from FHIR. And it includes some sort of care pathway support, even though the implementation of it's a bit challenging. So what we like to say in here, and this is my last slide, is that we are building an infrastructure. We are not building an infrastructure. We are building an infrastructure. We are thinking first on the business processes, which is the care pathways. After thinking in the care pathways, we are thinking in the information needs of all the actors or stakeholders involved within this care pathway. Then the third step for us is thinking about the applications, and the last thing is the technology. And this is always the order. Now, I was telling you before that the order right now, I have the feeling that this first we think in the applications, then maybe we try to fake some business process, and then, I don't know, the information. We think that the order is always this order, and that's what we are trying to do with our project. Well, following this road, we think that we will decouple. We don't think that we will decouple the data from the applications, and we will store them in an open format, which will be shared across all the ecosystem. And we think with this that we will enable data to effectively follow the patient. With this, we think that we will be able to deliver truly patient-centric care. And also we think proceeding in this way that we will help scaling up innovations. And yeah, well, that's all I wanted to share with you today. Yeah, thank you for your attention.
Thank you. Unfortunately, we don't have really enough time for questions anymore.